hypertonic. But when we're talking about this slide, we're talking about IV fluids, we're not talking about blood products. But it's the same effect. It's going to pull interstitial fluid into the vascular space. It's going to pull, if we give them enough hypertonic fluids, it will pull fluid even from the cells to the interstitial and then into the vascular space. Okay, so in this case, you might see that used in the context of somebody who has a lot of inflammation that we're trying to pull out of the tissues so the tissue doesn't die. Okay? Typical IV rates. So remember, in this situation, it is your provider, the primary care provider, who is actually prescribing these rates. These are not nursing decisions. These are PCP decisions. But it helps you to know, based on the rate, what's the intended purpose or the rationale that the provider is using that for. So the first one up there, let's see, where are we at? Are we at Stillwater? I think we're at Stillwater. What does KVO mean, Stillwater?
Vein open.
Keep vein open. So these people, we need IV access for some reason, and maybe they're a difficult stick. Maybe they're difficult to get IV access, so we don't want it to risk losing and have to keep poking them over and over again. So the physician might order KVO or TKO, to keep open. Okay, either of those mean the same, but typically it's a very slow rate. This is the equivalent of a medicine cup, those little plastic cups that you see in Skills Lab. A maintenance fluid rate can be low maintenance or high maintenance. So, Tonkwall, someone other than those who've already answered questions, how would a physician determine whether to use low or high maintenance rates for a patient?
Body size?
Did you say body size? Is that what you said? Was that what you said? That's a good guess, but it's actually not the primary reason, because again, irregardless of our body size, the human adult needs between 2 and 3 liters, or between 1.5 to 3 liters of fluid every day, regardless of how big that individual is.
Is it whether they can take oral medication or not?
Well, that could be one factor. If they're able to drink some, but they're not drinking very much, then we might be able to get by with the lower maintenance rate, because we're not providing them all of their fluid needs, we're simply supplementing what they're already taking in orally. But the primary reason deals with something else. What might it be?
What exactly you're giving through IV?
Well, no, the specific fluid, again, would not influence this necessarily.
Is it the gauge size of the IV?
Okay, we have a student here in Stillwater asking, does it have to do with clotting? And no, that's really the KVO rate. We're trying to prevent it from clotting off.
Would it be their vein size?
Enid or anybody?
Whether you're
I'll go dehydration.
Well, that falls under our replacement level there. Okay.
We have a guess that it might have to do with how well their heart works.
Ooh, very good. How well their cardiac and renal, because remember we said that you need a certain amount, but if you can't process and handle that amount, we're going to restrict your fluids, right? Remember we said hypervolemia, we might have to put them on a fluid restriction. Well, that includes IV fluids are factored into that overall daily intake. So even though we say a fluid restriction of 1,200 mils, we're talking about oral restriction, the physician is factoring in if he's giving any type of IV fluids at all to that patient. May not be giving anything because they're able to take in enough oral on their own. But basically somebody who has a cardiac problem or a renal function would probably fall under the low maintenance so that we don't put them into a hypervolemic state. And someone who has a healthy heart or healthy kidneys, the high maintenance rate. Remember, maintenance is meeting those needs, preventing new losses because they can't take it in orally or not adequately orally. Replacement, on the other hand, is now we're fixing somebody's fluid loss. Okay, we're giving it at a rate faster than we expect their kidneys to filter out. Do you remember what's our normal urine output unit? Yeah, 30 or less, we're in big problems.
Yeah.
What's normal?
50, someone said.
50 to 70. 50 to 70 mils an hour is normal. So of that, or 3 times of that, our intention is to replace what is missing. We're not expecting the kidneys to keep up with that. We're expecting some of that fluid to rehydrate those tissues, that interstitial space that is missing, or to rehydrate the vascular space because it's been depleted. And then the last one on there is what we call an IV fluid bolus. A bolus is a prescribed amount given as fast as gravity will allow it to infuse. These people are severely hypovolemic and may not survive if we don't replenish that in their vascular space quickly. And if they survive, they may suffer kidney injury if we don't replace it quickly. Okay, so these people, the physician may say, give normal saline 1,000 mils IV bolus now. And so that 1,000 mils will enter the vascular space in about 15 minutes. Question?
For patients that are hypovolemic, the
Do we
bolus.
only use it for patients that are hypovolemic? Yes, in the sense that sometimes we don't have definitive data to know how hypovolemic they are. So sometimes we do what we call a fluid challenge to see if we can improve their urine output. So maybe we've been monitoring someone, maybe they've had a heart attack, and so they really haven't felt very good for the last 48 hours. So their overall intake has been limited orally, but we really don't think they're that volume depleted, but all of a sudden we're getting urine outputs less than 30 mils an hour. So the physician will order a fluid challenge, an IV fluid challenge, to see if we can get a better urine output if we increase the volume in the vascular space. So we can use it as a test, if you will. Okay? What's the other test that we did in simulation this week to determine whether somebody is fluid volume depleted? Tonkwall? Remember?
Tilt test?
A tilt test, that is correct. So remember the tilt test, I described it the other day, last Thursday, what those parameters are. That tilt test helps us determine somebody who might be volume depleted. Remember, the tilt test can be skewed, however, if the person's on an antihypertensive med. So you have to rule out whether or not they're on an antihypertensive med. All right, any questions about IV rates there? Okay, let's take a quick break. Because we lost some time, so let's do a 6-minute break. I'll start back at 25 till 2.